My name is John Kitchens, and I'm a vitreoretinal surgeon with Retina Associates of Kentucky in Lexington, Kentucky. Welcome to this podcast, where we will be discussing the Alcon Unity VCS surgical platform. I have two guests with me today. Steve Charles is a vitreoretinal surgeon and founder of the Charles Retina Institute in Germantown, Tennessee.
Hi, how are you?
Thanks, Steve. And Maria Berrocal is an assistant professor at the University of Puerto Rico School of Medicine and a vitreoretinal surgeon with Berrocal and Associates in San Juan, Puerto Rico.
Thanks, John.
Let's jump into our discussion. Well, it's certainly very exciting to have any new technologies in retina, particularly surgical retina. It seems like every decade or decade and a half we have this evolution of our surgical equipment, and that time is now with the Unity VCS. Steve, you played a very important role in the development of Unity VCS and the Constellation, the predecessor. How is this platform different?
Well, I've been involved actually in 5 platforms over 50 years in practice, and so it went the Cooper Vision Accutome 8000, which is the first linear suction, the MBS, which was the first disposable cutter, and then the Acurus, which is the first systems integration approach, although it did not have a laser, and then the Constellation that you alluded to, and finally Unity. In every case, I've focused primarily on fluidics and how the cutter worked. And so in this instance, the major change is fluidics. We got better at each of those platforms I listed with respect to response time, but my goal was to make the response time not rate limiting, to make the surgeon response time the rate limiting factor, and we got there.
And I think the big evolution here, at least as it comes to the Alcon technology, is with the flow-based vitrectomy and utilizing a peristaltic pump. How is that different than what we're used to with the Constellation?
It's always fun to have a little sort of counterpoint in the discussion. We need to de-emphasize the term peristaltic pump because it's not peristaltic. It's a non-pulsatile displacement pump. Where do peristaltic pumps fit? Well, you have systole and diastole if you have ECMO, if you're on a cardiopulmonary bypass, or you're on a dialysis machine. It's important for the blood pressure to go like this. But that's not what you want, flow into the eye or flow out of the eye, to happen in vitrectomy. So by a dual arc pump that has 7 rollers that are 180 degrees out of phase from the dual arcs, now it's non-pulsatile. So it's intrinsically a flow device, but that's not really the point. The point is that we have 2 sensors, and on the pressure and vacuum side, and then we have 2 sensors on the flow side. I had to talk to Alcon engineers and some of the people in the marketing thing. No, it's not a 2-sensor machine. It's a 4-sensor machine. What do you mean? The pumps, the displacement pumps for both infusion and aspiration have a 1024 count encoder. So it knows exactly the flow rate into the eye and out of the eye. So I coined the term software-defined fluidics. That's an extension of a term that's been in military radio now for a little over a decade, where instead of it being a VHF, a UHF, or Marine Corps, Air Force radio, it's a software-defined radio. Now the Society of Automotive Engineers has adopted that terminology with vehicles. Once you have sensors everywhere and a time-sensitive networking in your vehicle with sensors in everything, anti-skid, braking, ignition timing, all that, now it's the software-defined vehicle. And just in the last 6 months, the manufacturing people are using that for automation. In fact, instead of saying flexible versus fixed automation, they now say software-defined automation. So, but you have to have sensing of everything. You have to have fast networking and fast controllers. So we have fast pumps.
Maria, how does that make a difference in the OR?
It makes a huge difference in the OR because it gives you really good control of the eye and the fluidics. You know, as good as the Constellation was, we still had fluctuations of pressure inside the eye, and if we were aspirating a lot, we would see the eye jumping into you, the retina jumping into you. With this system, what you have is absolute control. So the retina doesn't move. We are able to do shaving from detached retina in a very safe environment.
You know, from a surgeon's perspective, if you're moving from the Constellation to the Unity, how do you change what you do? What do you need to do differently? What are you going to see that's better? How does it change how you operate on patients?
Well, it is really a seamless system. You know, before, for example, I do a lot of combined cases, a phaco with vitrectomy to follow. Before, you had problems with having to put too much pressure, the wound being open. With this, you have a really, really stable system. You can switch from the phaco without having to pre-place the trocars. You go in and you have minimal movement of the retina, and to me, that is key. The fact that you can go 30,000 cuts per minute on detached retina, it allows you to really shave the vitreous from the surface of the retina and shave membranes. So it gives you a lot of more control of every step of the surgery, and it's much more efficient.
I might want to add a couple points here. I mentioned the emphasis on decreasing response time. How did we accomplish that? Not just by what I already described, but each generation of system had less air over fluid, no air, no gravity feed. So now we finally got to the goal, which was no air over fluid. No air over fluid on the aspiration circuit, no air over fluid. So what is that? Air is compressible. So now you have that real-time control that I've asked for. So where does that fit clinically? Maria already alluded to it, but vitreous is highly variable in terms of its consistency. You've got infusion fluid flowing in, you got pockets of liquid vitreous, collagen fiber matrix. And so what happens with Venturi-based control, which is a vacuum level control, Venturi is how you implement it. It doesn't matter how you implement it. What matters is what is it about physical parameter. It's flow versus pressure or vacuum. It's not Venturi versus peristaltic. That's a confusing way to think about it. So at any rate, you have flow that's all over the place. That's why the retina moves around. So when you say, oh no, I'm going to have this flow rate. So what do you do differently? Use the linear, the proportionality. Use the linear control of your foot pedal. Don't floor it and yell at the nurse because the vacuum's too high. It's like you buy a fancy car and you say, every time I drive the car, the wheels spin. Well, why don't you push the gas pedal down a little less?
Yeah, one important point with that is that before, when we went from being in vitreous to being in fluid or to being in air, we would have some collapse. But now the flow of fluid, irrespective of the medium you're in, is the same. And this is what provides the exquisite stability of the globe.
It's amazing, actually, when you go from fluid and you're doing a fluid to air exchange and you get to air, normally you have to be very careful and let off the foot pedal. This, you can keep it floored, and as soon as it hits air, it just stops.
Yep.
I mean, it is really, really brilliant. We have some data from a recent bench study comparing the Constellation Vision System in vacuum mode with 20,000 cut per minute dual blade 25 gauge hypervit probes and the Unity VCS in flow mode with 30,000 cut per minute 25 gauge probes. Using a bovine vitreous model, traction forces were measured under flow match conditions. Flow rate distribution was more consistent with Unity VCS, while Constellation demonstrated broader variability. Compared to Constellation with 20K probes, Unity VCS with 30K probes yielded 22 to 32% reductions in mean, peak, and maximum forces in vitreous mixture regions. The findings suggest that Unity VCS may offer safer vitreous removal, particularly in eyes with mobile retina, and may reduce the risk of iatrogenic retinal breaks during surgery. Steve, you are the author of this paper. What really prompted you to investigate this?
Well, first of all, you had to pick the right vitreous for the model, and it turns out bovine is better than porcine. And I didn't figure that out. The people in the lab that did the work figured that out. That was crucial, first step. Second step, how do you grab vitreous? So they came up with a brush that you use to clean lenses with these incredibly fine array of fibers and adhesively bonded those to vitreous. That was critical. And then strain gauges are super fast, so the response time of the strain gauge that measures force is not a problem. And so they have then lastly, you can't, when you have things running at 20, 30,000 cuts per minute, you can't ask a surgeon, what do you think about the traction? Because it's way faster than our eyeballs and our brain can respond. So it has to be technically instrumented in order to figure it out. And so getting that part right, so that meant if you hand hold the probe, you've already destroyed the data. So there's a micrometer stage that's motorized that advances the probe toward it. So now you don't have the variability of how is the guy holding it, is the guy pulling back, so on and so forth. And eliminating those variables, this is as realistic as we can get. And that was the core, to get it right. Because there's a lot of papers out there, I review them for literature like you do, that are just ridiculous of the statements they make. We proved this and that in the lab. You didn't. You just thought you did.
You know, Maria, how does this affect us intraoperatively? Does this make a real difference? Steve mentioned a surgeon can't really tell the difference when looking at it, but clinically, when you're operating on a detached retina, does it make a difference?
Yes, we all create iatrogenic breaks. We may not want to admit it, we may not notice it sometimes, especially the micro breaks when we're shaving the periphery, but they do happen. And by reducing these traction forces, we basically reduce the incidence of iatrogenic breaks, particularly on mobile retina.
And interestingly, there's appropriate emphasis on mobile retina. But the same thing's happening when the retina's attached because something's pulling back at you. So you're doing a quote-unquote simple photorectomy or an epimacular membrane or macular hole case, and you're not really thinking about the periphery as much, but you are tugging on it. And so this should reduce that force as well, even in the non-detached retina.
You know what's so interesting, Steve, and what I loved about the Constellation is after development, there was continued software improvements. Can we do better?
Well, I'm working on ways to go even faster on the cutter that I can't really discuss at this point. But for example, on the phaco side, some real experienced phaco surgeons came in. I just was there as an observer in the laboratory, and they said that this surge mitigation on an occlusion break is too aggressive for me. It's not allowing me to do phaco fast enough. They write code, changed it, that code got implemented. That's the point of software-defined fluidics. Sense everything, have super fast response time of the actuators that run the pumps, and now we have rotary valves instead of tubing compression valves with a motor that rotates the valve very fast. So when you say, I want less flow, by saying so with your foot, boom, you get it. Okay. Now the doctor, which is 400 millisecond response time, is the rate limiting step, not the machine. The machines used to take 2 seconds to respond to a foot valve command.
And Maria, when we're operating over mobile retina, there seems to be this cutoff point between you see things happening and nothing's happening. With this system, as you're shaving, how do you know things are taking place if you don't have that mobile response of the retina?
Well, because the machine tells you. It actually has a noise activation that tells you if you are in fluid or you're in vitreous, which is key, particularly for surgeons starting out.
Yeah, I think it's, when we talk about, a lot of talk is being given to the flow aspects of it. And Steve, I think you did a good job of alluding to the fact it's not just about the flow. It's about the sensor input and output. And I think talking about that infusion compensation that we have and how it differs from Constellation would be really, kind of a key take-home point. Not the outflow part, which we think about so much, but the inflow part and what the technology looks like there. Steve, there's a lot of press being given to the cut rates and outflow and flow-based things, but what about the inflow and the IOP control? How is that different with Unity versus Constellation?
Well, it's evolved. The very first systems were gravity feed, which means it's very slow in response. You got to grab the IV pole and move it up and down, or it's a motorized pole. Then came air over fluid, and that wasn't as good as people thought because it didn't vent. Then came vented gas force infusion. That was a little improvement. And then on the Centurion, with the phaco machine from Alcon, there's bag squeezing, but that has some elasticity in the bag, which isn't good. As I said, we don't like springs. So now we don't have any of that. We have a eddy current pressure sensor on the infusion circuit, and it's non-pulsatile. So again, let's not use the word peristaltic on the aspiration or the infusion side. Let's talk about a non-pulsatile displacement pump. So now we have smooth flow of fluid in the eye, and we're sensing the flow rate by the encoder. We're controlling the flow rate and sensing at the same time, and we know exactly what that pressure is. So that is absolutely mandatory to have the stability that Maria's been talking about, that you're questioning about. So it's critical, and it's particularly useful in phaco with an occlusion break. You're going to see it more in phaco than you'll notice it in vitrectomy. In vitrectomy, you'll see it, as you already alluded to, when you transition to air infusion. It's all about sensing and real-time networking of the elements. For example, if you had one processor, say, oh, we had blah, blah, blah processors really fast. No, we have 29 processors and 42 printed circuit boards and 4.3 million lines of code. That's what gives you this fluidic, software-defined fluidics that I keep alluding to, which again is about super fast response times on the infusion circuit, which is what you asked, as well as on the aspiration circuit.
Yeah, like you mentioned, it's most noticeable in phaco. As good as the Centurion is, when you have a very big piece of nucleus, of hard nucleus, as it goes by, you always get a little bit of collapse of the chamber. This does not happen with the Unity. And that you notice it in crystal clear corneas the next day.
And the capsule appreciates it.
Yes.
As someone who doesn't do phaco, do you notice it with lensectomy?
With lensectomy, you also notice it because you see it also in the vitrectomy side. The fluidics are so great that, and the sensors work so well that you do not have any lapse. You have no collapse of the eye, irrespective of how quickly you're removing pieces of lens.
And it's particularly true with dislocated lens material after a phaco complication, and we also have ozzel on the frag, which means that it's not bumping the lens material off the end, so it's torsional frag.
So more efficient, safer fragmentation.
For sure.
You know, there was a recent study comparing IOP control in a gas-filled eye between the Constellation vision system and the Unity VCS in a model eye. And during scleral indentation with the IOP set to 30 millimeters of mercury, Constellation produced IOP spikes of 93 plus millimeters of mercury without a vent, while Unity VCS maintained the set pressure at around 30 millimeters of mercury with faster stabilization without a vent. And in silicone oil injection with the IOP set to 26 millimeters of mercury, Constellation demonstrated IOP elevations up to 132 millimeters of mercury without a vent, whereas Unity VCS held pressure near baseline, right around 26 millimeters of mercury without a vent. This experiment was really set up as a worst case scenario. In the real world, it would be unadvisable to inject silicone oil while using the Constellation without having a vent ready to drop the pressure. Nevertheless, the experiment demonstrated some important findings. While the Constellation requires manual interventions such as venting to mitigate overpressure, Unity VCS provides automated precise IOP regulation, utilizing a hydrophobic filter, allowing the two-way flow of air or gas while preventing the reflux of fluids through the filter. Taken together, the results from this bench study suggest that Unity VCS delivers superior pressure control in challenging air-filled scenarios with potential to enhance surgical precision, reduce risk of iatrogenic injury, and improve overall safety during vitreoretinal procedures. So Steve, I don't think I ever really had the appreciation when I'm depressing an eye with infusion on, or when I'm going to oil and I haven't quite gotten the vent in just yet, what that does to the pressure. How has Unity been able to overcome that and keep us with physiologic IOP even during these extremes?
Let me tell you the clinical benefit, and then I'll tell you how. The clinical benefit, there's this term in cataract surgery called snuff syndrome. What's snuff syndrome? You got a 0.9 cup, you got advanced glaucoma, and the pressure was only elevated for a few hours after surgery. What's the big deal? The big deal is the patient can't see the next day. Once it's over with respect to the optic nerve. That has to happen. I see patients from, frankly, my competition that will have a light perception, hand motion vision, attached retina. They say, well, we had a normal case. Well, did you have any pain after surgery? A little. You know, and what does that mean? That means the pressure was 100 during, 30 minutes maybe, and they give these patients PRN pain medicines and cover the pressure increase with pain meds. That's a big deal. The other thing is that corneal edema, when you make corneal edema by overpressurizing the eye, it doesn't go away. It's absolutely instantaneous. I've done this in the lab when I was a resident at Bascom Palmer. When you raise the pressure, boom, there's corneal edema, because now it has random compaction of the collagen fibers in the cornea. But when you lower the pressure, it doesn't go away. Okay, so now you can't see. So that's a big deal. Okay, so in short, now how? The valve that we used to use for fluid gas exchange was an actuated valve. Now, in essence, it allows air to be pressed to be pushed back up to the infusion circuit when the eye is being pressurized by scleral indentation or by oil injection.
Maria, are you going to operate at different pressures? Are you going to do things differently because of this?
Well, what is great about this is that now we can operate at lower pressures in patients, for example, that have glaucoma, and you have a very stable, you don't have to worry about collapse, bleeding, etc. It's particularly useful for diabetics because you can have a constant pressure throughout. Also, I love doing direct silicone oil PFO exchanges, and many people have trouble with that because of not having a two-way valve. So this way you can do that, keeping the pressure constant at all times.
That you need a third hand basically to be able to do that and keep your light and keep your pressure, and now you
Not
don't
anymore.
have to.
And that's where chandeliers come in.
And will this make a difference in our non-glaucomatous patients? Let's say your average epiretinal membrane or macular hull, are we going to see better outcomes?
I think we will, because we're going to have less corneal edema when we have very stable pressures. When we are depressing, as Steve said, we don't really notice the damage that we do with short bursts of increased pressure in the eye. We never measure that, but I'm sure that happens too, that we're damaging the nerve fiber layer.
And I wonder, oftentimes when I'm depressing, even with a good retrobulbar block, you'll have patients who say, I feel that. Are they less likely to feel that aspect since you're keeping the pressure?
Absolutely, good point.
Welcome back to our discussion about the Unity VCS surgical platform. Now we'd like to discuss our own experience using this platform and offer some tips for surgeons who are either demoing Unity or integrating it into their practice. So when we think about integrating this into the operating room, what are some of the things, Maria, in the first handful of cases surgeons should look for and think about? And then what should they be adjusting and doing differently over their first maybe 20 or 30 cases?
Well, I think it's important for us to not look at the vacuum, because the vacuum is meaningless anymore. Before, we were always looking at vacuum. But the machine has done so many advances. The setup time is much faster. I use Ingenuity, but for people who don't, you can have a yellow light, which is very useful when you're doing a fluid air exchange. You can change the color of the lights. You also have many more aspects of the surgery that have been improved. I have to commend Alcon because they have improved every single step of the surgery. Starting that it has a very small carbon footprint. The packs are much less. There's less tubing, so there's less waste. This is a huge thing, particularly in Europe. We set it up quickly. We have the trocars come in easier. The cannulas they put in the eyes, so they dislodge a lot less. There's a little thing to stabilize the tubing. We have a 27 gauge chandelier, which is much improved to the 25. It gives you the same amount of light. And for me, the 27 gauge platform has improved in every single way. The light is better. The instruments have a stiffening sleeve, so they don't bend, they don't break.
I think this is the first platform that I've found as a 25 gauge surgeon that will make me say I can do every case with 27. And we'll get to that in just a bit. But first, you're right. So much attention to detail. Little things like you said, the tube holder for the infusion line. It's just brilliant. And it's so easy to use, and you can take it off and put it back on. The foot pedal, being able to control my Ingenuity from the foot pedal, and it is so well thought out with how you can navigate that. I don't have to ask my surgical scrub nurse to adjust things. I mean, every aspect has been looked at. Steve, you played a vital role with the trocar cannula development. Now, come on, how much better can we get with trocars and cannulas?
We talked earlier about elevating the pressure during scleral depression and silicone oil injection. Well, the pressure goes to about 100 millimeters of mercury when the trocar inserts, so the insertion force is less. That also means less stretching of the wound, so they close easier. And that's the main. But there's also a thinner wall tubing, a different design for the silicone oil. So silicone oil injection, even with, I prefer 1,000 centistoke oil. There's no rationale for 5,000, but many people use it. So now you can inject and aspirate the 5,000 centistoke oil quite rapidly compared to before. It was like, I didn't bring my lunch. I don't want to do 5,000 centistoke oil, you know. And so at any rate, that's safer. And then the Ingenuity integration is not just the control of it, but the fact that you have the data available. So you see the flow rate, you see the laser parameters, you see the cutting rate, you see what mode you're in. And that helps you when you have turnover of the staffing. I'm fortunate enough to have the same scrub techs every day, but we have to pay them. The surgery center doesn't reimburse us for that, so it takes away your income in surgery, but it's worth it to get it right. But most folks don't have that. And so being able to be in charge of the machine with your foot is terrific.
You know, and it's not just marketing. You think, oh, can you really tell a difference with the cannulas and trocars? You absolutely can. Sure you can. Well, not only when you put it in, but when you take them out. You're right, they close and look like sealed. There's no gap.
Biggest place you see it during insertion is if it's a post-op cataract surgery with lens material in the back of the eye or a retinal detachment. I still advise people to put a temporary suture in the cataract wound, but this way your chance of iris prolapse goes way down, which is a big deal. Eyes have been lost during trocar insertion. The eye was overpressurized and the whole iris came out, and then subsequently mismanagement of trying to replace the iris, the eye was soft and they got an expulsive hemorrhage. That has happened. I've seen cases.
You take a case that should be an easy fix and now you've made it in a 2-hour disaster.
Exactly.
Just because of that issue. You know, one of the things we talked about a little earlier in the previous episode actually was the intelligent fluidics and intelligent detection. And I love having that audible indication of when I'm in vitreous. I mean, somebody who's operated for 20 years, I still am not always sure when I'm fully engaged in vitreous. Maria, do you use this and is it helpful?
Yes, because I don't like necessarily staining vitreous if I don't need to with triamcinolone. So this is a really easy way to know where the vitreous is and if you have vitreous left over and where you're doing it. It makes you more efficient because you're not there in fluid thinking, you're removing vitreous.
I've been doing vitrectomy 52 years, and I agree with both of you. I don't like the triamcinolone. I've had sterile inflammation from that. The company that makes it says don't do it, and wrote a letter to every doctor, ophthalmologist in America. So I'm not a triamcinolone fan at all. I still miss vitreous. The fellows, I train fellows, they clearly miss vitreous, even 6 months into their fellowship. And the intelligent dissection does a good job. It's basically just measuring, because it's, again, sensor driven. You know the flow rate exactly because the encoder's on the aspiration side of the circuit, and you know the vacuum applied. So you back calculate with Ohm's law with a very complex algorithm. You calculate what the fluidic resistance is. So it doesn't know it's vitreous. I mean, if it's removing maple syrup versus water, it would know the difference.
You know, when I use this intelligent detection, I find I have to switch hands less often. You know, we have these phakic patients that we do, and I switch hands and I go, oh my gosh, I left so much vitreous behind. No doubt. And I love to give our fellows grief when I go, look at how much vitreous you left behind. But I'm like, I leave that much vitreous behind in a lot of instances. I find that I don't have to go back to my right hand again.
I think you're absolutely hitting a critical feature of this machine. It's terrific.
The other thing that's great is it'll give you an audible noise and a visual indication when you're fully occluded, which helps with induction of PVD. Mm-hmm. Maria, do you find that helps?
That is very helpful because oftentimes when you're trying to induce a PVD, you think you're aspirating, you're engaging vitreous, but you're not. That's why, the PVD is not being caused. So it's all these little features that make the whole surgery go by seamlessly.
Steve, why weren't we able to have this on other systems? Is it that closed fluidic system with no air there?
That's a critical part of it. They call that the plant in servo mechanism. Feedback loops is the plant is fast because of no air over fluid. But it's again sensor based too. You have to have real-time. It's pretty molded parts like the cassette vary a lot in size depending on the humidity when they make them and all that. So when you insert it, it calibrates those two sensors, and it does that in a very clever way. They're eddy current pressure sensors. Nobody else has done that. So plus or minus a tenth of a millimeter of mercury, and they're real time. Kilohertz sensor rates.
You know,
Fantastic.
a lot of talk about flow-based vitrectomy and having to go approach the vitreous and rather than have the vitreous come to you. Do you feel that or see that, Maria, when you're operating?
Yes, I think I do not want the vitreous coming to me, because if the vitreous comes to me, it means that I am exerting traction on the retina, and I can have micro breaks that I don't see. That's why we have so many recurrent detachments. Sometimes I don't know where these breaks came from. Well, it's from traction. So.
To Maria's point, 45 years ago, I was asked to make a poster at the Academy. It was in Kansas City, only time we've ever had it there. And they said, tell us the basic principles of vitrectomy. And I hadn't thought about it. And I said, cut vitreous and remove it in its original position, which is exactly what you just said.
And it's so perfect because then with the intelligent detection, you know when you're at a place, you've removed all the vitreous and you move to the next spot.
Yep.
And it's made me a better core vitreous surgeon.
No doubt.
And more efficient.
We have a lot of other enhancements. The tetraspot laser is one of them. And I'll have to admit, when I first saw the tetraspot laser, I thought, I'm pretty fast with laser. This is not going to make a huge difference. But after learning how to use it, there's a little bit of a learning curve there, it made me, and we have some time motion studies to back this up, maybe about 30 to 40% faster, more efficient with PRP laser treatment. Maria, are you using the tetraspot?
Yes, I love the tetraspot. I'm a firm advocate of the need of PRP in diabetics. There's no going about it. It is the standard treatment. It's what's going to prevent you from getting neovascular glaucoma. And with the tetraspot, you do it extremely quickly. I also like that you can use two spots, because in certain parts of the eye, you just use two spots. And you can also use it as continuous laser, which is how I use it around breaks. And I also use it in continuous mode as diathermy when there's some bleeding. And it also has a light. So if I want to, I operate without an assistant, and I like depressing myself, to laser the periphery or to see around. I even laser the ciliary processes in cases that have glaucoma, and this allows me to do it myself.
And imagine that you have that curved, illuminated 4-spot in a 27 gauge,
Exactly.
which amazes me. Steve, how physically could Alcon do this?
Well, it's a multi-core fiber, so there are 4 different cores within the tubing. They're not separate freestanding fibers. But that came from the telecommunications industry, more data. But what's interesting about the 4-spot laser, I've been probably the most vocal anti-buckle person on the planet. And I do that because I don't want to induce refractive error. Patients had LASIK or they've had an NTIOL. And now somebody, well, I just sleep better at night as a surgeon if I encircle everybody. I don't. The patients don't either, okay? Because they don't want to be a myope again, okay? So, and patients don't like pain and they don't like strabismus. And so therefore, I'm not a buckler. I've done 8,000 fit buckles, but I haven't done one in 20 years. I think it's an obsolete technology. There are papers in the literature that show, including papers from Norman Blair in Chicago, that show that if you make multiple rows of laser in the periphery, you reduce the rates of retinal detachment after vitrectomy. I do that in lieu of a buckle, okay? Well, with the 4-spot laser, it's much, much faster to make 2 or 4 rows.
Maria, 27 gauge seems to be the next evolution for a lot of surgeons. You've been using it for years, and I love how you show how beneficial it is for diabetic patients. But there's always been limitations. I don't like the lack of stiffness of the probes, the speed. Does Unity make 27 gauge a reality for the day-to-day surgeon?
The resistance to 27 gauge is because of the flexibility of the instruments and because the reduced flow. Those are the 2 main things. And this new platform has made the strength of the 27 gauge just the equivalent of the 25 with the Constellation. So anybody that's comfortable with using 25 in the Constellation will be comfortable using this. 27 gauge has so many advantages. First of all, you have to understand that smaller instruments let you do more fine maneuvers. The smaller opening lets you shave. It lets you shave stuff from vessels. It lets you get into really tight tissue planes so that you can blunt dissect, you can remove tissue from the surface of the retina. All of these maneuvers, the finesse that you get using 27 gauge is huge. But before, because of the flexibility, people were not comfortable with this. And I have to say that after I had been using and testing the Unity since August of last year, so I did it for about 5 months. And outside of the first 2 weeks when I used 25, I did every single case 27. And that includes removing nuclear fragments in cases where they had dropped, pieces of nucleus. It meant doing detachments. It meant doing traction detachments, difficult cases. And the advantages are immense. It also, the sclerotomies close beautifully, so that eye looks almost as if you hadn't touched it.
One thing that amazed me was being able to put in and take out oil,
Yes.
27 gauge. And the 27 gauge oil removal was just as fast with 1000 Cinestoke. I'm also a 1000 Cinestoke fan, as 25 gauge.
Yes, because the new universal tip that you use and the control of the flow allows you to do that. Before, I wouldn't use 27 if I was planning to use oil, just because it took forever. And now I use oil. It basically does it as quickly as 25.
And I used to suture all of my sclerotomies with 25 gauge and oil. No longer, because you get that great wound construction and smaller gauge. Another unheralded advancement was really the ability to have a 27 gauge chandelier that you can now put in any of the cannulas, which is something that you just look at and say, oh my gosh, finally. You now have the ability to move that chandelier. What's that add to your cases?
Well, it gives you a better view of different parts of the eye. You can use it as a single chandelier, or you can just use it as an extra light. For example, if you don't have an assistant and you want to sclerally press, you just put the chandelier in one of the... And so you have a lot more maneuverability. You require less assistance throughout all your cases, which is huge. I also do a lot of chandelier buckles. And the 27 is much better than the 25. The light is just as bright. The opening is really small, so there's less complications involved in that. And I do a lot of, I don't like encircling buckles. I really like segmental buckles and radial buckles. And for that, you can do a case in 15 minutes.
Steve, you start out on the Unity with 25. You want to make that transition to 27. Do you have to change your parameters at all?
Not really. You need a little bit more. If you're doing a vacuum preset, you run it higher. But again, you're doing flow control mode, so you don't really have to change anything. I want to make one comment on the wound closure thing. There was all this emphasis 20 years ago when 25 gauge vitrectomy first started on endophthalmitis. I have 3 in 48,000 cases. It's not a problem. Never really was, because bacteria are too lazy to swim uphill. Okay, but here's what does happen. Day 1 hypotony. That's a big deal. That's what leads you to rebleeding in the diabetics that Maria does so many. That's what leads you, even in other cases, particularly high myopes, you use PFO to fix a giant break, and the next day there's a high FEMA and you can't see the giant break because the pressure was 0 that night. Now, in a couple days, the wound's going to close, but that first post-op night, just a tighter wound closure, that's invaluable.
It's the number 1 cause of bleeding in the post-op period.
No question.
Well, listen, Steve, Maria, you guys have been amazing. Great introduction into the Unity VCS and the advantages from a technical standpoint, from a real-world standpoint. I appreciate you both for being on the podcast.
Thank you so much.
Thank you. Excellent questions. Terrific.